Being in the dark is something terrible. How much easier it is to plan if the whole picture were available pre-operatively. The OCT was used first for imaging of the posterior segment, the retina, optic nerve head, peripapillary nerve fiber layer, ganglion cell complex thickness, and so on. But now it is also available to the anterior segment surgeon for real-time, non-contact, high-resolution imaging of the anterior segment up to a portion of the ciliary body. The light that it uses is a 1310 nm low infrared laser energy, which has more absorption and therefore less penetration. Light returning from two parts are combined at the photodetector, and the strength of the combined return signal is a measure of the reflectance of a small volume of tissue. There are two modes to the Visante OCT: standard resolution imaging and high resolution imaging. It gives direct cross-sectional images, much like having an optical biopsy. In time domain or TD-OCT, the reference mirror moves one cycle for each axial scan, whereas in Fourier domain or FD-OCT, the reference mirror remains stationary, and instead the interference between the sample and reference reflections is split into a spectrum and captured by a line camera. The anterior segment OCT is important in LASIK. It gives preoperative pachymetric mapping, which along with topographical data gives valuable pre-op information. It also helps in planning enhancements and complicated cases like LASIK with thin flaps. In a case of post-PK severe astigmatism, ASOCT helps to determine the graft diameter and gauge strength of corneal scarring from previous surgery. It also helps in planning PTK and treatment of other post-LASIK complications. We have found that 110 and 120 micron flaps give good visual results and satisfactory predictability and planarity outcomes in a randomized controlled clinical trial. ASOCT is also useful in imaging epithelial ingrowths and other post-LASIK complications. We also had a post-LASIK patient with herpetic keratouveitis where we used Fourier domain OCT for documentation and follow-up of stromal infiltrates. In microbial keratitis, OCT images may also be used to measure objectively the extent and layers of involvement for serial follow-up and to assess the response to treatment and prognosis. ASOCT is also important in pre-operative evaluation of phakic IOLs to know the anterior chamber depth and white-to-white measurements, as well as post-operatively to study phakic IOL vault. In this patient with phakic IOL implanted 1 year back, we noted the development of cataract. On ASOCT, we found an absence of vault and crystalline lens ICL contact. This patient underwent ICL's removal and cataract removal with foldable IOL implantation. Glaucoma applications of ASOCT include assessment of angles, as well as provocative tests, bleb morphology, patency of iridectomy, and the ostium can be assessed post-operatively, as also tube patency and position, as well as anterior segment morphology. ASOCT in this patient with a mitomycin C enhanced thin-walled leaking bleb showed a direct path of leak, which made the decision for bleb revision easier. Post-op follow-up OCT shows a functioning, patent, good bleb. Corneal high-resolution ASOCT makes it possible to pick up early Fuchs as an increase in corneal thickness. Corneal pathology, if any, is picked up and depth and density of scarring can be assessed, thus making the decision between deep anterior lamellar keratoplasty and Decimet's stripping automated endothelial keratoplasty versus full thickness PK more objective. Graft-host junction morphology is well seen in ASOCT, as also anterior segment morphology such as bridging anterior synecdoche, etc. Corneal implants as well as lamellar procedures are also visualized. We have used ASOCT to document depth of penetration of foreign bodies such as a thorn. ASOCT can also be immensely useful in anterior segment analysis, especially in opaque corneas with poor media clarity. Minute structures may be visualized with OCT. Decimet's detachment can very often be detected only on ASOCT in eyes with post-cataract non-resolving edema. IOL position, centration and tilt can be evaluated with ASOCT. We also introduced the advantage of ASOCT in documenting AC reaction in edematous and hazy corneas with compromised anterior chamber visualization. We've also compared 700 micron clear corneal incisions with 2.8 mm incisions made with keratome and found wound healing and resolution of coaptation loss or endothelial realignment was observed to occur earlier in microphacoid wounds without extension. Iris cysts can be imaged very well with ASOCT, though the part behind the posterior pigment epithelium may not be seen. It is also of great use in imaging ocular tumors such as OSSN to detect any deeper invasion. To sum up, the ASOCT is a valuable information tool and has now become must-have knowledge for anterior segment surgeons.